Next, we're going to be looking at blood transfusions and blood typing. So when it comes to blood transfusions, the cardiovascular system minimizes the effects of blood loss by reducing volume of affected blood vessels, stepping up production of red blood cells, but it can only compensate for so much blood loss. Loss of more than 30% of your blood will result in potentially fatal severe shock. So we have to restore blood volume, because death from shock may result from that low blood volume, so we might replace blood first with a normal saline or a multiple electrolyte solution called a Ringer solution, and this mimics plasma electrolyte composition. Now this is just to replace volume, because the replacement of volume restores adequate circulation, but it won't replace the oxygen carrying capacity of red blood cells. To do that, we'll have to either do a whole blood transfusion, but those are usually only when a blood loss is rapid and substantial. We might use infusions of just packed red blood cells, and that's plasma and white blood cells removed. It's just red blood cells, and those are perfect to restore oxygen carrying capacity. Now, blood banks usually separate donated blood into its components, and that shelf life for that blood is about 35 days. So let's talk now more about human blood groups. So we can talk about that donated blood and talk about a transfusion reaction that can be fatal, but is a mistyping of blood. So the human blood groups are going to be established looking at red blood cell membranes, because they bear many different surface markers called antigens. An antigen is anything perceived as foreign that can generate an immune response. So when you give someone donor blood, the recipient's body can see those surface markers, and in that respect, they are antigens. Now, red blood cell antigens are referred to often as agglutinogens because they promote clumping of blood if it's mismatched, called agglutination. Mismatched transfused blood is perceived as foreign, or is often perceived as foreign, and may be agglutinated and destroyed. So that's the potentially fatal transfusion reaction. So when we're talking about human blood groups, we simplify it because there's at least 30 naturally occurring red blood cell antigens, or surface markers. Again, we're looking at the surface of red blood cells to look for these antigens, or these surface markers. But the presence or absence of each antigen is used to classify blood cells into different groups, like MNS, Duffy, Kell, Lewis. These are really weak agglutinogens, though, and less likely to cause a clumping or fatal transfusion reaction. So unless a patient needs several transfusions, we don't usually type these. But what we do type are the ABO antigens and the RH blood group antigens, because they cause the most vigorous transfusion reactions. Therefore, they're the major groups typed. So let's look at the ABO groups first. The ABO groups are based on the presence or absence of two agglutinogens, A and B, on the surface of red blood cell membranes. So for example, if you're type A, your red blood cells only have the A agglutinogen on their red blood cell surface. If you're type B, your red blood cells only have the B agglutinogen on their red blood cell surface. If you're type AB, your blood cells have A and B agglutinogens on their red blood cell surface. And if you're type O, think of it as type 0, because you don't have A and you don't have B agglutinogens. So keep in mind that agglutinogen can be subbed for antigen, and antigen can be subbed for cell surface marker, which is just a cell protein found on the surface of the red blood cell. So your blood may contain preformed antibodies as a result of your blood type. If you're type A, you have type B antibodies. If you're type B, you have type A antibodies. If you're type AB, then you have no antibodies because they'd fight your own cells. And if you're type O, you have A and B antibodies, and those would be in your blood plasma. You essentially have the anti-antibodies against the blood types you don't have. And this is going to act against transfused red blood cells with the ABO antigens that are not present on a recipient's, or if we're thinking of ourselves as the recipient, your blood. And we actually have these antibodies, anti-A and anti-B antibodies, formed in the blood at about 2 months of age. They reach adult levels by about 8 to 10 years of age. And these are one of the only examples of pre-formed antibodies in the human body. Most of the time, our immune system only creates antibodies after we have been exposed to the foreign substance or foreign pathogen that causes disease. This pre-formation before exposure is novel. It doesn't happen otherwise. All right, so here's a quick overview. This is an illustration of the different blood types. So you can see for blood group AB, we have A and B surface markers, or agglutinogens, on the red blood cell. For blood group B, we have just B agglutinogens, or surface markers, on the blood cell. Type A, just A antigens, or surface markers. Type O, no A and no B antigens, or surface markers. Note that you have antibodies in the plasma. Antibodies are not in the cell. Antibodies are not on the surface of the cell. The anti-antibodies are in the blood plasma. And those antibodies are going to be present against the blood types the person doesn't have. So for example, blood group AB has A and B antigens. So they have no antibodies because the antibodies would fight their own blood cells if they did. For type B, they have anti-A antibodies because they'll accept type B blood, but they won't accept type A blood, so those antibodies would fight it. Now, if you're type A, you have B antibodies. So your body would fight off type B blood, but not type A. And if you're type O, you don't have A and you don't have B surface markers. So the blood types they don't have are A and B. So they have both anti-A and anti-B antibodies. Type AB is actually called the universal recipient. It can receive A, B, AB, and O blood because it has no antibodies in their plasma to fight against any blood type they're given. And then type O is called the universal donor because if you take just their red blood cells, so think a packed red blood cell transfusion, and give that to a recipient, then that can be accepted by anyone. But if someone's type O, they can only receive type O blood because they contain both A and B antibodies in their plasma. So universal donor is type O, universal recipient is type AB. All right, let's also talk about the Rh blood groups. There's about 52 named Rh agglutinogens. They're called Rh factors. Common ones are abbreviated as C, D, and E. We're really going to talk more about the D antigen. And if you're Rh positive, that indicates you have the D antigen. If you're Rh negative, you don't have the D antigen. And it's more common to have a positive blood type than it is to have a negative blood type. 85% of Americans are Rh positive. So if you're wondering, what is this Rh? You haven't heard of it. You have probably heard of having a positive or a negative blood type. What Rh factor essentially is an extra surface protein. If your red blood cell has Rh on it, your blood type is positive. If your blood cell does not have Rh, then your blood type is negative. Keep this in mind. I'm going to say this as kind of a disclaimer. There is not an Rh negative protein. There is only an Rh protein. You have it, you're positive. You don't have it, you're negative. Now, Rh can actually cause some problems because anti-Rh antibodies are not preformed. They're not spontaneously formed in those individuals who are Rh negative. But there is a condition, or really I should say a situation, where anti-Rh antibodies can form in an Rh negative individual when they first receive Rh positive blood, or during the process where an Rh negative mom is carrying an Rh positive fetus and gives birth. And that's the first exposure. Not really a problem except for that sensitization step, because upon second exposure to Rh positive blood, if you're Rh negative, or upon second exposure to Rh positive blood, if you're an Rh negative mom having another Rh positive fetus, your anti-Rh antibodies will actually result in a transfusion reaction, either making it dangerous for you to have that transfusion, or attacking your fetus's blood. So those are conditions that can result. Now, in the case of the Rh negative mother who has an Rh positive fetus and is sensitized the first time that happens and has an effect on her fetus the second time that happens, we're looking at a condition called hemolytic disease of the newborn, also known as erythroblastosis fetalis, that only occurs when you have an Rh negative mom with an Rh positive fetus. Again, the first pregnancy, the first exposure to Rh positive blood during birth is not going to affect the mother or the fetus, except that the mom will synthesize anti-Rh antibodies because her body will see the blood of the fetus during birth. But the first baby is born healthy. But during the second pregnancy, the mom has anti-Rh antibodies, and they're able to cross the placenta and destroy the red blood cells that are Rh positive of the baby. So the baby then generally has to be treated with pre-birth transfusions, exchange transfusions, but we can prevent this entire first exposure, this sensitization step, to protect the second child. So what we will do is use an immunoglobulin called RhoGAM. This is a serum containing anti-Rh, and this will prevent the Rh negative mother from ever producing antibodies against the Rh positive blood of her fetus. Now, that's just an example of a transfusion reaction with Rh negative versus positive that can occur. So what you're seeing there is someone who is Rh negative can receive Rh positive blood once, but not twice, at least not without having a transfusion reaction that second time. And then an Rh positive person can receive Rh positive or negative blood, doesn't matter. But clinically, we don't really know if an Rh negative person has ever been exposed to Rh positive blood. So clinically, we give negative blood to negative blood, and then for positive, they can get negative or positive. Now, transfusion reactions can occur more than just with Rh. It can occur if you have a mismatched blood of any type. Donor cells are generally attacked by the recipient's plasma agglutinogens. Another way to say that is the donor blood cells are attacked by the antibodies that are in the blood plasma of the recipient. And they will clump together. Again, clumping together is called agglutination, and they will agglutinate and clog small vessels. They tend to rupture and release hemoglobin, and they release that hemoglobin into the bloodstream. And our bloodstream is not ready to handle all that protein. And so oftentimes it gets stuck in blood vessels, or it might get stuck in the kidney tubules. So this can not only destroy red blood cells and diminish oxygen carrying capacity, but it can decrease blood flow beyond a blocked vessel. And if the hemoglobin does end up in the kidneys, the kidney tubules can get blocked, and that can lead to kidney failure or renal failure. So what we do is we tend to treat the symptoms. Symptoms like fever and chills and low blood pressure and rapid heartbeat and nausea and vomiting. So we tend to give fluids and diuretics to wash out the hemoglobin because we really want to prevent especially that kidney damage. All right, so keep in mind though that transfusion reactions can happen whenever you have mismatched blood. Now, one way to prevent this is a patient pre-donates their own blood, and that's stored and available if needed. They might do this before a big surgery, but that's called an autologous transfusion. So keep those symptoms in mind when a mismatched blood transfusion. All right, let's move on though and talk a little bit more about blood typing and kind of quick and easy blood typing that might be done, say, in an emergency scenario. They might take donor blood and mix it with antibodies against common things that cause clumping or agglutinogens. And so if those clumping particles are present, we'll see clumping and we'll know not to give this donor blood to that recipient. And blood is generally typed for the big agglutinogens, ABO and Rh factor. And we do this by cross-matching. That is the mixing of the donor blood with antibodies against commonly known agglutinogens. So here's an example of cross-matching. So in the first example at the top, we see clumping in A and B. There were anti-A antibodies and anti-B antibodies in A and B respectively, and the donor blood was put on those circles with the anti-antibodies mixed with water, and we saw clumping. So that means that the donor blood had A and B antibodies in the plasma. Sorry, the donor blood had A and B antigens on the red blood cell surface. So this would be packed red blood cells essentially. Then type A, we only see a reaction in type A. Type B, we only see a reaction in type B. Type O, no reaction. There's also some diagnostic blood tests that we want to talk about just briefly. The examination of blood can yield information on a person's health. If you have a low amount of red blood cell, that's low hematocrit, that might be seen in someone that has anemia. If you have blood glucose tests, they might check for diabetes. Leukocytosis, that's an increase in the amount of white blood cells, can signal that someone has an infection. So examining the blood can give us information about a person's health. We can also do a microscopic examination of blood to look in variations of size or shape of red blood cells. Like you may be able to indicate anemia by looking for macrocytic or microcytic red blood cells. There's also other diagnostic blood tests, like a differential white blood cell count, where you look at the relative amount or proportions of each white blood cell. Usually if you see an increase in a specific white blood cell, that could help you with a diagnosis. We can also assess hemostasis using prothrombin time and platelet counts. We can do a comprehensive medical panel or CMP to look at blood chemistry and check for various blood chemical levels. We might do this to indicate liver or kidney disorders. And we might also be looking at a CBC or a complete blood count that checks for the formed elements, the hematocrit, and the hemoglobin. All right, so to finish up, let's try some practice questions. Which of the following shows the correct sequence of hemostasis from start to end? Now, this question wasn't covered in this video, but it was covered in the prior video. So if you didn't watch that, go back and then come back to this question. All right, the correct answer is vascular spasm, then platelet plug formation, then coagulation. That is the correct sequence of hemostasis or the stoppage of bleeding. All right, next question. Blood type is determined by blank. And that's going to be glycoproteins called antigens. So those surface proteins are just sugar proteins that are present on the surface of erythrocytes. So we look at the surface of blood cells to determine blood type. True or false? Hemolytic disease of the newborn can develop when an Rh negative woman is pregnant with her second Rh positive child. You said true, you're correct. It is only going to be seen during that second pregnancy. It might be seen during a third as well if she's never treated, but it's going to be seen for the first time upon that second pregnancy with an Rh negative woman and Rh positive child. All right, individuals with blood type A have, you said B, you're correct. If you're type A, you have only A antigens on your erythrocyte. If you were A positive, you would have A and Rh antigens on your erythrocyte. What about this question? True or false, individuals with type AB blood are known as universal receivers. You said true, you're correct. And that is actually it for chapter 16. So make sure you watch all parts and then come back and review or send me an email if you have questions.